to Bear in Mind, the Brown Psychiatry podcast, clear current content about mental health. I am the host, Dr. Tracey Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm Camila, Cosmo, Psychiatrist and Co-Editor-in-Chief.
I'm Dr. Stephen Curtis, Psychiatry Resident and Script Editor for today's episode.
First, a content warning.
In this episode, we will talk about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice. Depression is a tough battle, and although nowadays we have a range of medications and treatments to help, some people do not respond well enough and may have what we call treatment-resistant depression. Lately, a lot has been talked about ketamine and psychedelics as a potential game changer for these cases of depression.
Some studies have shown that psychedelics and ketamine, a drug used for anesthesia, might help with depression. In 2019, the FDA, or the U.S. Food and Drug Administration, approved a specific formulation of ketamine called S-ketamine for the treatment of treatment-resistant depression and those with depression with suicidality.
So join us today to talk about ketamine, psychedelics, and the recent finds in this exciting area of psychiatry. We have here Dr. Linda Carpenter, who is a psychiatrist and professor of psychiatry and human behavior at Brown, where she investigates the mechanisms of mood and anxiety disorders, as well as new treatments for them. Welcome, Dr. Carpenter. It's great to have you here.
Thank you for inviting me.
Wonderful to have you here, Dr. Carpenter. There are so many medications that are currently approved for the treatment of depression. But why are people so excited about ketamine and psychedelics, and what exactly are they?
Yeah. Well, these category of drugs are ones that have been around for a long time. They've been used in ancient cultures. They've been drugs that are what we would call street drugs, used illicitly. And now they're being formulated by pharmaceutical companies and tested in clinical trials for people who have depression or other mental health disorders like post-traumatic stress disorder. I think the excitement comes from the fact that these studies, these clinical trials, which have tested the drugs in patients with depression, show that they're effective for relieving depression symptoms when other antidepressants, standard ones, the ones that we're familiar with in the pill form, have not worked. So they represent a whole kind of class of new opportunities if the data continue to show that they're safe and effective, a whole new sort of category of drugs that we may be able to use to help our patients with depression and a number of other psychiatric disorders.
Mm-hmm. Are there any risks associated with ketamine and psychedelics? Any contraindications to using them?
Sure, yeah. So first of all, let me say that the drugs are early in the course of being tested in clinical trials where you give them to patients in what we call a randomized fashion. Some patients get the real drug, some patients get a placebo or a sugar pill, and then you evaluate the effects and you evaluate the safety. So before a drug goes through to the point where it's on the market and available for commercial use, pharmaceuticals can sell it and doctors can use it to treat their patients, there's this whole phase of testing. And during the testing, the side effects are identified, and they characterize the people who got the real drug, how many of them had the side effects compared to the people who got the sugar pill, right? Mm-hmm. So with drugs like ketamine and S-ketamine, and again, S-ketamine is already FDA approved and available under the brand name Spravato. People may have heard or seen advertisements about that. There are side effects. Some of the most concerning side effects are when these drugs are combined with other drugs. So if you were to take a drug like ketamine or S-ketamine at the same time you were taking a stimulant like amphetamine, some of the drugs that we prescribe for attention deficit disorder, or if you're taking it together with sedating drugs in the categories called benzodiazepines or other ones that make people drowsy, those things together can be very dangerous. They can be dangerous because there are effects of ketamine and S-ketamine on your heart and on your blood pressure. For a temporary period when you take these drugs, your blood pressure increases and your heart has to work extra hard. So people who have unstable blood pressure or who have unstable heart disease, these could be particularly dangerous drugs. And for people who are combining them with alcohol or with sedating drugs, they could become unconscious. They could become excessively sedated and And that could be dangerous because then your breathing slows down and you can have vomiting. There are mild side effects that come and go each time you have a dose. And that's a little bit different than the pills that we prescribe for depression. When you take pills, antidepressant pills, you might have some side effects for a few days or a few weeks, and they gradually dissipate over time for the most part. These drugs, when you give a dose, in the immediate half hour to hour after each dose, the person has a side effect which is a little bit like what you might feel if you're waking up from anesthesia from a surgery, or if you woke up from a colonoscopy or something. You're drowsy, you're disoriented. Some people hallucinate a little bit, or they have an experience that we call dissociate, where things seem unreal, they sound unreal, or they look strange. And some people are very sedated, they're very drowsy. And others become a little more agitated. There's some nausea that sometimes comes right after a dose, and very rarely somebody might vomit, but nausea is not uncommon. But those things pass. Those things pass within about a half hour, and people who get these drugs are very closely monitored throughout a 2-hour period. You can't drive home after you've had a dose of ketamine or esketamine. You can't typically use heavy machinery or function in a very sharp way for the rest of the day. It's like a small procedure in terms of having an anesthetic. And in fact, as you mentioned, ketamine is an FDA-approved anesthetic. So you're using a slightly different dose for a short-term treatment. And ketamine, of course, is given through an intravenous line as a solution, and esketamine, Spravato, is given as a nasal spray that a person sprays up each of theirs. But there's a monitoring period. So those side effects happen during the dose, but then the dose goes away, and the next day you don't have those side effects. They don't continue.
And then there's another topic a lot of people seem to be interested in, microdosing, or taking very small doses of a psychedelic to avoid any significant sensory changes, such as changes in the way that you see, hear, or feel things, has been receiving increased attention, with people stating that they feel improvements in their mood, their productivity, and their concentration. Is there any evidence that this is true?
Yes. Well, so first, let's go back to what psychedelics are, because there's a number of different ones here, and I don't want to group them all together. The ones that I've just spoken about, ketamine and esketamine, right, are really not classic psychedelics, but they have some similar effects. In the psychedelic category, we have a number of other drugs. Some of them, like I mentioned, are drugs that you might have heard about as street drugs, like LSD, or ecstasy, which is called MDMA, is another word for that. And then there are a number of others. Psilocybin, which is found in natural form in mushrooms, is in the category of psychedelics, and then there are a couple others. So when we talk about microdosing, I want to say first that this is not a treatment that has been studied in a scientific way. It hasn't been evaluated in clinical trials. What we know about microdosing is what people report, and there have been a couple published papers where researchers have gone around and asked people who microdose, what are your experiences? What do you use? What kind of doses do you use? What experiences do you have? And so people report often that they have positive experiences with microdosing. The problem with it is that it's something that's happening outside of the world of sort of science and medical testing. So we don't really know, we don't have a way to test it like, you take the placebo, the sugar pill, and you take the microdose, and we'll compare everybody's safety and measure the outcomes on validated scales so we can determine what depression symptoms are changing, if any. So there are reports. There are reports from lots of people who microdose and claim that they experience benefits. The side effects are hard to assess. You can ask people. But again, we can't say something about, well, that's efficacious or that's effective to treat a mental health disorder, because we just don't have the kind of scientific data that we would need to answer that question. So that's certainly out there, and there are people that are combining lower doses, maybe you'd call it microdosing, or maybe it's an intermediate dose of drugs like ketamine with psychotherapy. And there you could understand, well, there's some potential for the psychotherapy to make people better. So when that's happening, they could be reporting positive experiences. There's a whole category of a psychedelic called MDMA, which is being tested in large clinical trials, multi-centers around the world, actually, as a treatment for post-traumatic stress disorder. And the drug is not given just alone. It's given together with a special type of psychotherapy that's given by a therapist who's trained in how to do it in a supervised setting. And that has proven in several clinical trials to be effective for relieving symptoms of post-traumatic stress disorder. But together, these doses with psychotherapy. Now, I'll say if you take a regular dose of ketamine or esketamine, you may be just too sedated to do psychotherapy for the next few hours, right? Because people can be very disoriented. But in the lower doses, combining it with psychotherapy may be viable, and that's something that people are starting to look at.
Interesting. So at this time, intranasal esketamine is FDA approved for the treatment of depression. Is there any other evidence that other routes of administration of either esketamine or ketamine are effective?
Yes. In fact, very, very recently, I'll talk about IV ketamine first. IV ketamine is intravenous administration of ketamine, right, for treatment-resistant depression. Recently published a very large clinical trial that was funded by the National Institutes of Health, our taxpayer dollars at work. And this funded researchers to do a study where they randomized, they flipped a coin and put people in one group or another. One group got what we call ECT, electroconvulsive therapy, and the other got IV ketamine. And ECT, which is sometimes described by lay people as shock therapy, but it's electroconvulsive therapy, is a treatment that we think is really the gold standard for treating the hard-to-treat depressive episodes, right? It's considered sort of the best treatment when everything else fails. So in this particular study, they compared the gold standard, which is ECT, to intravenous ketamine infusions. And a large study, over 500 people, went to one group or the other. And what they found was that the IV ketamine treatment was equally as effective. We call it non-inferior. It was equivalent in how well it worked to ECT, our gold standard. And there were fewer cognitive side effects. And by cognitive side effects, some of the side effects that people have with ECT include having some trouble with their memory and their thinking. And the ketamine caused more of this short-term dissociation after each of the doses, but was less likely to cause people to have problems with their thinking and their memory afterwards. So this study, this large study, was a very important kind of proof that IV ketamine is very effective for treatment-resistant depression. In fact, as good as our best available treatment.
We understand, based on what you are telling us, that psychedelics and ketamine have been investigated in several trials for treatment-resistant depression. But what we are wondering is, do you think that is there any room for ketamine and psychedelics being used earlier in the treatment algorithm for depression?
Yeah. So I guess when I think about that question, using it earlier, you're asking, like, when a patient comes into their clinician and they have an episode of major depressive disorder, what does that doctor or nurse or clinician choose first, right?
Yes.
And when we think about how we make that decision, we want to know which treatments have the best efficacy, which means we know they work the best for the most people, and which have the fewest side effects, right? And then there are other considerations like cost, access to drugs, right? Sometimes insurance companies will cover something and others won't cover something, right? So access certainly plays a role in deciding. We don't have the kind of data that we would need to determine if it should be what we'll call first-line treatment, the first choice, right? You would need to do some comparisons in a scientific study and randomize people so that they get assigned from a flip of a coin to this treatment or that treatment, and then compare how well one works compared to the other, how few side effects or how many side effects they are, one against the other. And those sorts of large studies are used to develop what we call algorithms, as you mentioned, which help clinicians decide which comes next after. If this doesn't work, what do I do next? And there's sort of, an order that you can follow. sometimes two things end up working equally as well, and then there are other factors that come into consideration when you try to decide. But it's possible that these drugs could come earlier. Certainly, one reason that they would not would be because they require a lot of observation. Mm-hmm. They are delivered in a special setting now, like a medical setting where you're monitored with your blood pressure and your heart rate and your oxygenation. Because you can't drive home after you get a dose of S-ketamine or ketamine. Right now, these are not treatments in the doses that are kind of most popularly being examined in scientific research and clinical trials. But because they require all of that, that's certainly less convenient, and it's going to be more costly than just having somebody take home a pill and take it. Mm-hmm. But it's possible that in the future there will be versions of these drugs that can be administered differently. As you mentioned, there's a range of work that's happening with different doses, and maybe down the road. But I think for now, we would probably use something that's more convenient and less expensive, like a pill, as a first choice.
Mm-hmm. In talking about coverage, in your experience, are patients facing any challenge to have, for example, the treatment with ketamine?
Oh, yes. Yes, that's absolutely a problem. Often when a new drug comes out, there's a lot of excitement and there's a marketing and people see it and they want to try it. And then, the first thing that we encounter is that the insurance doesn't want to pay for it. And often new treatments are very expensive. And certainly the drugs that we've talked about today, ketamine and the psychedelics, are not inexpensive. They require these hospital settings and multiple people to monitor, so they're not inexpensive. With the first one, Spravato, the brand name drug for S-ketamine, it's my understanding that all insurance companies pay for it, but it's been complicated because they don't necessarily pay the hospital or the clinic that delivers it. These drugs are called scheduled drugs. They're controlled substances. They're not ones that you can pick up in the pharmacy. If your doctor prescribes Spravato for you, you can't go get it yourself. It has to be taken by a special carrier to the clinic where it's going to be administered to you. So there are barriers. There are barriers related to the fact that they're controlled substances, that they're expensive treatments, and it'll take some time before insurance companies put policies together and figure out how they'll pay the clinics and the clinicians that administer the drugs. It's starting to happen. There are here and there a few clinics and a few insurance companies that will cover these, at least Spravato at this point. For IV ketamine, we don't have insurance coverage around Rhode Island. However, elsewhere in the country, there are some hospitals that have some insurance companies that are covering IV ketamine treatments, just like they cover ECT, the electroconvulsive therapy.
All right. So you touched on multiple barriers just now, but I was curious if there are any other significant barriers to accessing either ketamine treatments or psychedelic treatments.
Right. In addition to the insurance issue, whether or not your insurance company covers it, there are presently a limited number of places, clinics, medical clinics around the state and around the country where patients can access these treatments. We're starting to see a few providers in the Rhode Island area. Butler Hospital is planning to open up an outpatient esketamine clinic in about 2 months. We're just waiting for some insurance contracts to come through. And once that happens, people who are interested in the treatment or referred for the treatment for treatment-resistant depression can go through a process of describing or providing their treatment history, and then there's a pre-authorization to see if they meet eligibility. So there will be criteria that people have to meet to get treatment with esketamine, which is Spravato. Similar situation with IV ketamine. I do want to be clear, though, that what you talked about earlier, microdosing, that is not actually a treatment for any medical disorder. That's not FDA approved. As I said, it's not something that's been studied. I think microdoses is when people are taking upon themselves to get a supply of illicit substances and using some amount that they determine is a small dose. And that is outside of what we do for treating depression or other mental health problems.
Thanks for clarifying it.
Thank you so much. So I just want to make sure I mention for our listeners, because we've mentioned ECT, that we have a previous podcast that they can listen to hear more about ECT by our colleague, Dr. Alvaro Oliveras. So you can check out a previous episode to learn more about that. But I wanted to ask Dr. Carpenter, is it possible that ketamine or psychedelics could be useful in the treatment of other psychiatric illnesses?
Yeah, absolutely. At present, we have excellent data for IV ketamine to treat depression and intranasal S-ketamine to treat depression. But there's been a large series of clinical trials using some of the other psychedelics, MDMA, assisted therapy for post-traumatic stress disorder. And there have been pilot studies. Pilot studies is when they have a small clinical trial, not large enough, maybe not randomized, not the definitive one that's going to lead to FDA approval. But there have been studies across a number of psychiatric disorders, substance abuse, anxiety disorders, depressive disorders, people with cancer, pain disorders. It doesn't look like the effects of some of these drugs are limited at all to depression, also OCD, obsessive compulsive disorder. So the potential is great. And that's not unlike other drugs that affect serotonin. In fact, drugs like psilocybin have profound effects on this chemical in the brain called serotonin. And that's similar to some of the drugs that we use to treat depression and anxiety and also other psychiatric disorders. And particularly because these are controlled substances, they have potential for abuse. And I don't think we really talked about that yet.
Right.
And actually that may be a barrier for some because at least at present, people who are taking other medications that might increase the risk or who have substance use disorders are really not candidates for these medicines. Medicines like ketamine and S-ketamine have some potential for abuse, and some of the other psychedelics do as well. And, I think that the field doesn't really have a good sense yet of how significant that risk is and for whom, who's at risk for becoming addicted or dependent on these medications. It doesn't seem to be the case for everybody who takes it. In fact, Spravato is not a drug that causes a dependency or an addiction. Neither is IV ketamine, but there is some potential for abuse outside of a medical setting.
So is that, at this time, is that a contraindication for the use of ketamine in the clinical practice with someone with a prior history of a substance use disorder?
It is. Yet, of course, some of these drugs are being examined as treatment for substance use disorders. Right now, in the first wave of implementing this in medical care, people who have at least a recent history, right? If you had a very remote history, you've been in remission a long time, that might change it.
So what does the future looks like for ketamine and psychedelics research?
With regard to psychedelics, probably one of the next things that we'll see is the MDMA-assisted psychotherapy for post-traumatic stress disorder. There's enough data there that soon the FDA, the government's regulatory agency for drugs, will be looking at that drug and deciding, is that going to be a approved treatment, right? So what the future looks like for clinics is that there will be specialty clinics where these treatments are administered that require special observation and special monitoring. And then the future for the research will be studies looking at these and other disorders, looking at what we call maintenance. So when we test a drug, we figure out, does it get somebody better in, say, 6 weeks or 8 weeks? What we need also to know is once they're better, how do you keep them better for the long term, right? So when you're taking a pill, you swallow it every day, your depression gets better, you stay on it for what we call maintenance therapy. For the psychedelic drugs, you come in, you get a dose, you go home. You come in, get a dose, you go home. And so right now, the way they're dosed is you do 2 a week for a couple weeks, and then you taper it down to 1 a week for a while. And then if you've really benefited, if your depression is in remission or you've responded to the drug, which means you've had a lot of your symptoms improve, then the next question that we need to work out is how do you continue to stay well for the next bunch of months and years? And of course, people who have treatment-resistant disorders have been struggling chronically for years, sometimes for decades. That's not uncommon for the type of patients who will get these treatments. So, the next stage of research will be looking not only at what are the other disorders, but how do we best dose these things for the long term.
Mm-hmm. So just to clarify, because I know that some people are going to be very interested in this point. You clearly mentioned before that there are some medications that people cannot be taking, should not be taking for safety reasons, like stimulants, for example, with ketamine or S-ketamine. And so if someone were coming in abusing stimulants, they'd certainly be not a candidate for ketamine or S-ketamine at the time for safety reasons. But let's say somebody has a recent history of a substance use disorder with alcohol or with opiates, and they're newly sober and they're depressed during that time, and they're looking to ketamine or S-ketamine to help them. What would be done in that situation? Is it an absolute contraindication? Is it a judgment call by the clinician? Is it a conversation with the patient? Mm-hmm. So outside of safety, what would happen in that situation?
Yeah, I think that would be decided on a case-by-case basis. Yeah. We always have to think about the risks and the benefits and, the particular risks that each patient brings to the moment have to do with a number of things, right? Their support system, the kind of treatment they have, how extensive the history of dependence or addiction has been. So, right. There are some contraindications for what you can be taking at the moment you come in for your dose. But in terms of a history of addiction or substance use disorder, those are the things that would be decided on a clinical basis.
Gotcha. Okay, so in addition to the psychiatric interest in psychedelics, there's also a significant cultural momentum that is pushing for decriminalization and legalization of these medications. Does that pose any risk to their future of use in medical settings or in other conditions such as schizophrenia or substance use disorders?
Yeah. There is some risk if some of these drugs become readily available. There is some risk that people will use them without the kind of monitoring that's required. That's been determined with thousands of patients, at least with drugs like ketamine and S-ketamine, that monitoring is necessary. It's medically necessary so that people don't die when they take these drugs, so they don't have terrible side effects. So there are risks that people will be able to access them, misuse them, run into trouble with addiction, side effects, and death, and that might slow down the progress that we're making moving them forward as helpful medical treatments. Yeah.
Right.
So one follow-up question. Some of the members of the community may have heard of or had experience with things such as Special K, ecstasy, magic mushrooms, acid, and things of that nature. And I was just wondering if you could clarify how that's different from how we're talking about MDMA, psilocybin, and ketamine in the medical sense.
Yeah, that's a great question. Patients often ask about how S-ketamine or IV ketamine are different than Special K. And Special K is a version of ketamine that's a street drug. It's often mixed with other things, actually. It's not necessarily purified ketamine, the quality and the grade that's used for ketamine when it's used as an anesthetic to put people to sleep for procedures, or when it's used to treat depression. So some of the side effects that are actually associated with Special K, if you look over the years, people who've used a lot of Special K have bladder disease and other sorts of side effects. Those didn't appear to be problematic when you use the purified drug in a controlled dose in the clinical trials for medical treatment. With regard to psilocybin, it is magic mushrooms, of course, but when you use it for a medical treatment, it's controlled in a laboratory and put in a capsule so that it's purified, and it's the exact number of milligrams is standardized. Those sorts of controls that make these medical products make them safer than what people get on the street, because again, things that people get on the street might not be what they think they are. They might be mixed with other ingredients, and oftentimes those mixed in ingredients are responsible for some of the most horrific side effects that people experience. So I think those are the main differences. Some of the chemical structure is, the chemical structure is similar. It's just the way it's controlled and delivered.
Right. It's safety being the paramount thing when we were creating
Absolutely.
these things. It's just very dangerous to take these medications off the street not knowing what you're getting.
Absolutely.
And could be lethal for people. So we do want to emphasize that.
That's it.
Thank you so much, Dr. Carpenter. This was really helpful. We appreciate your presence here, and your kindness in sharing your expertise and your knowledge. So now a take-home message to bear in mind.
Ketamine and psychedelics are exciting developments in the field of psychiatry. They work in new ways as compared to our standard antidepressants and offer hope as new treatments for people who haven't found relief from their depression yet. However, it is also important to keep in mind that more research trials are needed to be done to make sure these treatments are safe and really effective for the treatment of depression and other psychiatric illnesses. While these new drugs offer hope to people with depression, only take these medications if they have been recommended to you by a licensed medical professional, and please only do so under supervision.
And if you or someone you know is feeling depressed or having suicidal thoughts, please contact the Suicide and Crisis Lifeline. Call or text 988 or access 988lifeline.org. The Lifeline is a 24-hour toll-free phone line for people in suicidal crisis or emotionally overwhelmed. You can also go to the nearest emergency room and ask for help.
So thank you for listening to our podcast. For more information related content, please check out our Instagram, Facebook, and YouTube channel. Bear in mind the Brown Psychiatry Podcast. Thank you.